y escuchar una muy buena presentación del doctor Terpos. Seguramente que muchos de los que estamos acá lo conocemos. El doctor Terpos es profesor de hematología de la Universidad de Atenas, desarrolla su actividad en el Hospital Nacional Alexandra, en la ciudad de Atenas. Ha sido y es revisor de más de 70 journals, ha recibido premios que tienen que ver con la investigación y con la terapéutica clínica y ha realizado conferencias tanto a nivel nacional e internacional, más de 100 o de 350 en el caso de cursos de capacitación y de formación. Así que, doctor Terpos, bienvenido, es un placer tenerlo por primera vez en Argentina. La modalidad de la presentación, que está focalizada en el mieloma de alto riesgo y evidencia del mundo real, será que luego de la presentación del doctor va a haber un espacio para 2 casos clínicos que podamos votar y discutir, y por eso todos tenemos el votador electrónico. Y las preguntas deben ser con micrófono y en español, que va a tener traducción simultánea. Así que cuando quiera.
Thank you so much. Thank you for the kind invitation to be for the first time in this beautiful city and this beautiful country. They told me for this second meeting that I have in your very nice place, yeah, it's okay for me, to talk about 2 important things. The one is the high-risk multiple myeloma, which is an unmet need now. We don't have a lot of good therapies for these patients. And the second is the real-world data for different proteasome inhibitors and the differences between the studies and the real world. So let's start from the high-risk myeloma, and this is my disclosures. And as you know, multiple myeloma is a very heterogeneous disease. We start from the progenitors, the monoclonal gammopathy of undetermined significance, going to the smoldering myeloma. You see that from the beginning we have different subclones into the clone that we call multiple myeloma and we can recognize. And as we go to the myeloma and then to the very end stage, either extramedullary disease of plasma cell leukemia, you can see that more aggressive clones, some of them that were not present in the initial diagnosis of multiple myeloma, are growing, and you have these very aggressive clones to give the refractory disease. So we have primary events and primary abnormalities that we can detect, and these are trisomies present in approximately 45% of the patients. We have IGH translocations. Some of those are thought to be of very high risk, like the translocation 1420, which seems not to be so bad, mainly the 1114, which is not bad at all. But the translocation 414 and 1416 correlate with poor prognosis, and they are included in the revised international stages system. But we have a lot of secondary abnormalities that are monosomies, mainly of chromosome 17, the deletion 17p, which is very common as we go from the one relapse to the other. We see more and more patients to have this very bad feature of myeloma. And it is important to know not only if this is present, but for how many cells it is present. If it is 20% of the plasma cell, it is different. If it is 40%, if it is more than 60%, it becomes extremely poor prognostic factors. So it was a very, very nice paper in Nature Communication in 2014 from Nicola Bolli, when he used to work in Boston, and describes very nicely the clonal evolution of multiple myeloma. So you can see here that when we have this type of clone at diagnosis, then at the time of relapse, you can see one small clone or 2 clones there that were not present or started to be present at diagnosis. But then you have other cases where you can see smaller or bigger clones at the time of relapse not to be present anymore, while on the other hand, several other clones to come up. So you can see that myeloma is extremely heterogeneous. Only 3% of the total population have only one clone at the time of diagnosis. And these patients, of course, they have very, very good prognosis. But many others have more than one clones, 3 to 5, and then at the time of relapse, as you can see, either other clones appear, or some of the clones that were present at diagnosis, they become bigger, and other goes out of the clone. And the prognostication of multiple myeloma has a lot to do with this clonal heterogeneity. So we had initially the ISS staging system based only on beta-2 microglobulin and albumin, and then the revised one takes into consideration not only the ISS, but also LDH and the high-risk cytogenetics, deletion 17p, translocation 414 and 1416. And you can see that in stage 3 that we have ISS3 plus high LDH or one of the 3 high-risk features, the median overall survival is less than 4 years. And this remains to be an unmet need. And also within this group of patients, we have patients who have extremely poor prognosis that have a median survival of less than 18 months. So metaphase cytogenetics and mainly the FIS is important in order to define the high-risk cytogenetics. The interactions between the genetic abnormalities in the myeloma clone and the microenvironment, either the immune cells or the osteoclast in the osteoblast, make the myeloma cell to have high-risk status, suggesting that the microenvironment probably give growth advantage to the clones that are more resistant to chemotherapy or anti-myeloma drugs. And this is extremely important. Furthermore, we do know that in different places, myeloma cells have different genetics. So we had a very nice study, and Gareth Morgan had published this paper 2 years before. You can see here biopsy of different areas gives different results regarding the genomics of the plasma cell. So in the same pelvic area, you can see 1, 2, 3, 4 different subclones at the time of diagnosis being present in this myeloma patient. And we do know that if we see extramedullary disease in the lymph nodes or the liver, compared to what you see in the bone marrow, many times you have different genetics. And this is why when we see extramedullary disease, you have poor prognosis compared to patients without extramedullary disease. So what factors determine prognosis in myeloma? They are patients, of course, specific factors, but also disease-specific factors. And when we talk about patient-specific factors, we talk about age, comorbidities, and frailty. So the age is an important factor. As you know, elderly patients are doing poorly in all the different systems. This is from Mari V. Mateos, a meta-analysis of many Spanish studies suggesting that patients above the age of 65 have poorer PFS and overall survival compared to those patients who are younger than 65 and receive more aggressive therapies, including autologous stem cell transplantation. Frailty is extremely important. You can see that the frail patients, according to the IMWG score, have very low overall survival. The 1 year probability of survival is only 78% compared to 96% of the fit and 93% of the unfit patients. And in the multivariate analysis of prognosis, you can see that the frailty is even more important than the ISS3 disease. The frailty has 3 times more probability of dying compared to ISS3 disease, which has a probability of dying of 1.7% higher compared to ISS 1 and 2, even higher than the high-risk cytogenetics. So you understand how important it is, frailty, and it is very good that Takeda, from what I've heard, they have provided you with an IMWG application score in order to be easy for you to assess frailty in your clinical practice. Regarding disease-specific factors, of course, we have the revised ISS system that I previously shown to you, which has applicability in all the different patient subpopulation, in those who were transplanted, in those who did not transplanted, in those who received immunomodulatory-based regimens up front or bortezomib-based regimens up front. Regarding high-risk cytogenetic, I want to remind you that the FIST is the standard procedure that is recommended by the International Myeloma Working Group for the definition of deletion 17p, translocation 414, and translocation 1416. And we do know now that it's not only the presence of this abnormality that is extremely important for prognosis, but other important cytogenetic abnormalities offer poor prognosis. This is a very interesting report by Hervé Avet-Loiseau in the last AS meeting in December, where it has given different scores according to different factors. So you can see here not only the presence of deletion 17p and translocation 414 that receives not very high score in this system, but the addition 1q. In the previous meeting that we have with younger hematologists, we talked about some cases, and one of these cases had an addition 1q, and it had very, very bad prognosis. You can see here that it takes a score of 0.5, a little bit higher than the translocation 414. And also deletion 1p is an extremely important poor prognostic factor, along with trisomy 5 and 21. So based on these scores, you have three risk categories that you can see: the low, the medium, and the high risk. And you can see that in this cohort of patients, the high risk has a median survival of approximately 2 years. So you can see that with this scoring system, we are able to distinguish, even within the ISS3, a subgroup of patients who have even worse prognosis of 2 years, and this is extremely important. So based on this publication, when it's going to be in print, I believe that the recommendations will change and will not need to check only T414 or deletion 17p, but also 1q gain, deletion 1p, trisomy 5 and 21. As you all know, the plasma cell leukemia offers a very bad prognosis, either as a primary plasma cell leukemia or secondary after 2 or 3 relapses of multiple myeloma. And you can see that patients with plasma cell leukemia in all different studies, this is the study from Litzrock, offers very bad survival, 1.8 years of overall survival, only less than a year of progression-free survival. Extramedullary disease, and this publication came before the data from genetics. I think that now that I show you the genetic data, you understand why the presence of extramedullary disease is so poor prognostic factor. You can see here that the event-free survival and the overall survival are extremely lower compared to the non-extramedullary disease patients. You can see the 5-year estimate of overall survival is 60% if the patients have no extramedullary disease versus 31 for those who have extramedullary disease. And this is based in Arkansas experience, where PET-CT was used in order to find if the patient, the extramedullary disease in all patients at diagnosis. And as I previously shown to you, the gene expression is totally different in these patients with extramedullary disease, and in different extramedullary places, the genetics is different. Gene expression profiling from the Lilt rock, you can see that we have the different scoring systems. Unfortunately, these scoring systems, although in the specific population, showed that there were patients who had very low, very bad prognosis. Unfortunately, when these scoring systems were tested in other populations, like in the French population, they had no applicability, so these scores have not been used anymore. But a very interesting result is this study of Gareth Morgan and Nikhil Munshi that defined the DNA driver of aggressive clinical behavior. Here you see that we have a high-risk group that was defined by a recursive partitioning using either biallelic here, biallelic TP53 inactivation, or amplification here of more than 4 copies of 1q21. So it's not only the presence of the addition 1q, but also how many alleles have the amplification, how many copies have the amplification. If it is more than 4, you can see here that the survival is very bad. And here also, if we have the inactivation of biallelic TP53, the prognosis is extremely poor. It is the 18-month probability of survival, only 35 and 37% respectively. So we have this high-risk double-hit group of newly diagnosed patients identified by genomic analysis, and based on this data and the data that I previously shown to you by Hervé Avet-Loiseau, I believe that the high-risk group definition is going to be changed very soon. Based on the standard high-risk definition of translocation 414, 1416, and deletion 17p, we know that at diagnosis, approximately 20 to 25% of the patients are categorized as high-risk disease, while at the relapsed refractory setting, this is going up to 40 or 50%. And as we have more and more relapses, then the secondary events that includes the chromosome 17 abnormalities are growing up. What we give in these patients, do we have a very good treatment for these patients? This comes from the HOVON study and the EMN2. It is a combination study from different European centers giving 4 cycles of VCD, and then we had one randomization between high-dose melphalan or 4 cycles of VMP, and then we had another randomization for consolidation with 2 cycles of VRD or non-consolidation, and all patients received lenalidomide maintenance. Here, according to the treatment, according to the, let's say, policy of the different centers, the participants could have 1 or 2 transplantations, and this is very important. So you can see here that approximately 207 patients received 2 transplants versus 208 who received 1 transplant. So the result of this study in the high-risk subgroup showed, first of all, that patients who had received a transplant with the blue color versus those who have not received a transplant but also VMP, you can see that there is a big difference for the median overall survival, and 3 years, 74% versus 61%. For deletion 17p patients, this was 74% versus 51%. For revised ISS3, it was 69 versus 47%. But more importantly, the high-risk cytogenetic groups who received 2 transplants versus those who received 1 transplant had a better overall survival. The probability at 3 years was 85 versus 73%. So you see that when the first, let's say, recommendation from this study is that when you have a patient with a high-risk cytogenetic who is eligible for a transplant, don't be afraid to give 2 transplants because this is for the benefit of your patients compared to 1. Even revised ISS 2 and 3 patients have overall survival advantage if they receive 2 transplants versus 1 transplant. The other very important study, it was from the Netherlands myeloma study group, the HOVON, and the German group, comparing PAD, which is Velcade, adriamycin, dexamethasone, versus the standard VAD. But this is important because we had a maintenance with bortezomib here versus thalidomide. The result in the FISH subgroup analysis, which was presented by Pieter Senneveld after a median follow-up of 10 years, showed that patients with translocation 414, addition 1q, and deletion 17p had advantage with bortezomib, both in the PFS and the overall survival compared to thalidomide. You can see here the overall survival at 60 months was 75%, 79, and 72% in patients who had not this abnormality, and 52, 57, and 65% if the abnormality was present. Regarding VRD, we have here a study from Ajay Anuka, published in Leukemia some years before, where you can see in the high-risk patients, they gave the standard VRD induction with 4 cycles, autologous transplantation, and if the patient had at least a PR, had 2 cycles of VRD consolidation and VRD maintenance for the high risk. And using this strategy, you can see that the median PFS was 32 months and the 3-year overall survival probability of 93%. I think this is one of the best that we had to date, the best result in high-risk population. So the message from this study is that maintenance with lenalidomide is not enough, but you need possibly a combination with Velcade and maybe with dexamethasone. This is a study from GMEMA, which evaluated the impact of bortezomib or lenalidomide-based induction in high-risk cytogenetic patients who are not eligible for a transplantation. So they took into consideration all the phase 3 studies in the elderly population who received either Velcade or lenalidomide-based combinations. And this was an oral presentation in the last ASH meeting. You can see here that if you compare VMP versus RD as first line in the high-risk population, with the VMP, the median PFS was 31 months and the RD 15 months, suggesting that lenalidomide alone is not good for the high-risk population, while on the contrary, Velcade and proteasome inhibition is extremely important. The median overall survival, as you can see here, approximately 18 months of difference in favor of VMP versus lenalidomide and dexamethasone. And if we go to the different abnormalities, if we had 1 or more than 2 abnormalities, including translocation 414, 1416, and deletion 17p, in all subcategories, bortezomib-based therapy was much better than lenalidomide and dexamethasone or lenalidomide plus melphalan and prednisone. You can see the median PFS, 31 months versus 15, the overall survival at 4 years, 61% versus 44. Everything was better if bortezomib was into the treatment. And finally, in the subcategories of the specific abnormalities, again, you can see that in the deletion 17p, in translocation 414 and 1416, the presence of bortezomib, mainly in 414 and 1416, almost double the median PFS and the overall survival at 4 years. So in all, high-risk cytogenetic proteasome inhibition is extremely important, while lenalidomide alone is not enough with dexamethasone. How about the relapsed refractory setting? We have the results of the Tourmaline 1 study, which compared ixazomib, lenalidomide, and dexamethasone. Ixazomib is the first oral proteasome inhibitor, which is given once per week for 3 weeks and 1 week without the drug. In this study, it was combined with lenalidomide and dexamethasone versus lenalidomide and dexamethasone. And if you see with the red color is the high-risk cytogenetic patients with IRD, you can see that the median PFS is 21.4 months with high-risk IRD, totally comparable to the 20.6 months of the standard risk patient, and much better for what lenalidomide and dexamethasone can achieve. How about the other combinations? Even with daratumumab, lenalidomide, and dexamethasone, which seems to be the best combination for the standard risk disease, you can see here that the median PFS at the time of that analysis had not been reached. Now it is 44 months for the standard risk, but when you go to the high risk, this goes down to almost half, 22.6 months. With carfilzomib, lenalidomide, and dexamethasone, 23.1 months. With ixazomib, lenalidomide, and dexamethasone, 21.4 months. With elotuzumab, lenalidomide, dexamethasone, 21.2 months, suggesting that for the high-risk disease, there is almost no difference between the 4 combinations, dara, len, dex, carfilzomib, len, dex, ixazomib, len, dex, or elotuzumab, len, dex. And this suggests that when you have such a patient, probably we don't have the ideal therapy, but you have to choose based then on safety. And to my opinion, IRD is one of the best and more safe regimen for this specific category. If we give other combination without lenalidomide, then the results are extremely disappointing. So for carfilzomib and dexamethasone alone, for the high-risk disease, the median PFS is only 8.8 months, and this comes from the Endeavor study, where KD was compared to VD. And in the Pollux study, in the Castor study, where daratumumab was combined with Velcade and dexamethasone, in high-risk disease, the PFS was only 11.2 months. So you can see that only a combination of lenalidomide with a proteasome inhibitor or with monoclonal antibodies gives you results that goes up to 20 to 23 months. Only carfilzomib, both daratumumab with Velcade and dexamethasone, the results are extremely bad. How about pomalidomide? Pomalidomide seems to be efficacious mainly in deletion 17p patients. You can see here that in this population with deletion 17p, the median PFS seems to be the same with the standard risk. Of course, in that study, pomalidomide was given only with DEXA, so it is only 4.6 months and 4.2, but it is not good for the translocation 414. And this is the study that was published in December 2017, so 1.5 years before, about ixazomib, that with combination with lenalidomide and dexamethasone prolongs the progression-free survival. Here is the deletion 17p patients with or in combination with translocation 414 and or 1416, median PFS 21.4 months. Here is the translocation 414 alone. The results from 21 months go to 18.5, and this is with addition 1Q alone, that this goes even down to 15.4 months. The safety data seems that IRD is extremely safe, like Len-Dex. We don't have extreme toxicity with the exception of diarrhea and some peripheral neuropathy, which is a little bit higher than lenalidomide and dexamethasone alone. So the conclusion for the high-risk data from the Tourmaline study is that the PFS is significantly improved in both deletion 17p and translocation 414 with very good safety profile. This is approximately 21.4 months and I believe that this is one of the most efficacious combinations that you have, mainly in the elderly population where you don't have any other toxicity like the other drugs, carfilzomib, that has excess of hypertension and cardiac toxicity. So in summary, in high-risk cytogenetics in multiple myeloma defined by translocation 414, 1416, and deletion 17p, I think that this is going to be changed very soon. Addition or amplification 1q in deletion 1p is going to be added along with trisomies like 5 and 21 based on the data that I have previously shown to you, but also the numbers of TP53 biallelic inhibition or the addition 1q alleles if are more than equal to 4. I think this also is going to be included. It is definitely an unmet need because these patients have very poor prognosis, and the Tourmaline study suggests that IRD is a very good combination for these patients. No difference with other combinations, but with better safety profile. And with that, I would like to thank you for your attention. I don't know if we are going to have questions now or... Okay. There is also about the real world, so how do you want to go? To go for the next one and then we have all together? So the second part of my talk has to do with the real-world evidence, because we know from many studies that the real-world data are different from the phase 3 studies that we see. And so when we have patients in front of us, many times the data from the phase 3 studies cannot be, let's say, will not be sufficient for the decision in these patients, mainly because these patients have comorbidities, they are frail, so they never included in clinical trials. For example, in this publication 1 year before by Paul Richardson in Blood Cancer Journal, you can see that for carfilzomib, we have the median duration of treatment to be in clinical trials 9.2 months, and when you go to the registry analysis, it's only 3.4 months, so it's 1/3 below. And the same, we see it in other studies. This is a registry study from the US, which evaluated the combination of a proteasome inhibitor and lenalidomide in relapsed refractory setting. And you can see here, between January 2008 and December 2016, in this Humedica, this very large US-based database, 343 patients received VRD, 139 KRD, 50 patients IRD. You can see here the median age, so you can see that the physicians prefer to give IRD in the elderly patients that, according to the data that I've shown you previously, have a poorer prognosis. And you can see that the median duration of treatment, as you can see here, it is 8 months for VRD, 6.3 months for KRD, and has not been reached for IRD. I understand that the comparison includes very low number in IRD compared to the other, but it gives you an idea that a patient with IRD, with the data that I'm going to show you, can remain on treatment for more time, and maybe this is why the time to next therapy in this population with IRD, which is much elderly compared to KRD, you can see 8 years of difference between the two, and we talk about relapsed setting, is translated to better time to next therapy. This is the data that you see for the first time, because the publication was sent 3 weeks before in British Journal of Hematology. And when we firstly reported this data in the ASH meeting in 2017, we had a median follow-up of only 9 months. So here now we have a median follow-up of 15.9 months, which is totally comparable to what there is in the Tourmaline 1 study. So based on that, we can have a direct comparison between the two studies that I'm going also to show you. We had 155 patients, median age 68.1, 4 years more than the median age of the Tourmaline 1 study. You can see also that the median treatment duration in months, it is 9.6, and the median PFS of this population is 27.6 months with a CR or stringent CR rate of 15.6. We've seen in this study that the overall response rate and the median PFS is closely resemble the outcome of the Tourmaline MM1, which was 78% of overall response rate. We had 74%. The median PFS was 21%. Here is 27%, but we had more patients with who received the treatment as second-line therapy. The most important thing is the comparison of the progression-free survival between the two studies. So here with the blue curve, you can see the IRD population of our study, the real world, and with the red, you can see the IRD study of the Tourmaline. So you can see that they are totally comparable. So the overall population of the real-world named patient program is overlaid of the Tourmaline MM1 study, so they are totally comparable. Another very important thing is that patients who received the treatment as second line in our study had the median PFS of 27.6 months, while if they received it as third or fourth line of therapy, it was for almost 20 months. Regarding prior transplant or non-transplant, there was no difference in PFS. But I think that the main message for the study is that the PFS that you expect in the real world is similar to the study, which had lower median age, 64 instead of 68 in our study, and of course the criteria of the phase 3 study and not the real world that you see in front of you. Regarding safety, because we had more frail patients and more patients who had received bortezomib before, we had peripheral neuropathy at a higher number compared to the phase 3 study, 35%. However, the majority of these peripheral neuropathy was reversed with the reduction of the dose to 2.5 milligram. We had 8% of infections, 5% of herpes zoster, very low number of hypertension, and only one patient who had a fracture. Regarding safety, a total of 9% of patients discontinued treatment due to adverse event and no other important safety issues. And the conclusion from this real-world data is that the IRD is an effective and safe regimen in this real-world setting, and there was no difference regarding efficacy from the phase 3 study. Patients were able to receive the oral triplet as for long duration in this setting with a low rate of discontinuation, and we have very long PFS even in patients who underwent an autologous transplant. Similar results came from other real-world data with IRD. This is the Czech registry, where you can see that in patients, 127 patients who had a median age of 66 years, so it is more near to the Tourmaline study. The majority had received, the vast majority, bortezomib as first-line therapy, and you can see that the overall response rate is 67%, and the median PFS was in total 20.6 months. This is a pool analysis of two studies, the Czech registry that you've seen previously with 113 patients and 50 patients from a study whose name is InSight that tries to see what is the standard of care in the different countries, in different myeloma population. So we expected to have in the INSIGHT real-world study approximately 4,000 patients. We believe that we are going to have this number by the end of summer. So 50 of these patients had received at least 4 cycles of IRD in order to be included in this common report that was presented by Gordon Cook in the British Society of Hematology annual meeting 1 month before. So as you can see here, these 163 patients, 50% of them received the IRD as second-line therapy. And in the Tourmaline study, the median again was, prior lines of therapy was 1. Regarding other characteristics, the median follow-up here is 9.3 months. Just to remind you that it's 15 months in the Tourmaline study, and the majority of the patients had received the drug at a median of 4 years after the first treatment. 90% of the patients had received bortezomib before, 60 had received transplant, and 42 patients had received thalidomide. You can see that overall, the median duration of therapy was 14 months, and the median duration of follow-up, as I told you, 9.3 months. Regarding effectiveness, you can see that the median time to first response was 1.1 months, and to best response, approximately 4 months. As you can see here, the overall response rate, 74%, with more than VGPR, 31% of the patients, totally comparable to the response rate from what we've seen in Tourmaline 1 study, which was 78%. Here is 74%. Regarding PFS, the median PFS, 20.9 months. If it is second-line therapy, the median has not been reached, and the 12-month probability of PFS was 70%. Again, the median PFS of 20.9 months was totally comparable to the Tourmaline, which was 20.6. And the overall survival, of course, the median overall survival was not reached in this cohort of patients because the data are not very matured. Regarding the safety and tolerability, dose reduction with ixazomib in only 18% of the patients. The conclusion of all these studies of the real-world data, I think it is obvious that we have exactly what you expect in the real world from what you have seen in the phase 3 study with a population with inclusion criteria that is not frail. So you have in all these studies a median PFS around 20 to 27 months, very near to the MM1, which is 20.6, response rate of 74%, which is very near to the Tourmaline 1 also. It is a very well-tolerated combination, all oral combinations, low rate of discontinuation, only 4% because of ixazomib. And I think that the message from these studies is that the IRD is an extremely safe drug, and you can expect, even in more elderly patients than that of the Tourmaline 1 study, very good results. Just 2 very brief cases from our practice. This was a 74-year-old woman diagnosed with myeloma in 2016, treated with VMP, achieved complete response, but after 8 months, she lost the response because of deletion 17p that was not present at diagnosis. Just to show you this analysis, which showed that the triplets are better than doublets, and you can see that almost all triplets, with the exception of Daral and Dex, which is very good, mainly for the standard-risk disease, all the others are equivalent in this study of Pieter Sonneveld group that was published 2 years before in Journal of Clinical Oncology. Regarding high-risk disease, I have shown you previously that the hazard ratio in IRD is very good, only 0.54 compared to 0.70 with KRD and with Pollux, which is 0.53. So it is one of the most efficacious combination in this population. Patient received IRD in the named patient program, and although with VMP achieved only 12 months of time without treatment, without progression, after 3 cycles he achieved a VGPR, and the next relapse was after 23 months of IRD. So she did extremely well. The second case was an elderly patient, but with standard risk cytogenetic, but with a history of hypertension and a heart stroke. And I believe that the majority of the patients, at least in Greece, the Greek Society of Cardiology told me that after the age of 70, only 12% of the patients are free of hypertension, atrial fibrillation, other arrhythmias, coronary artery disease, or heart problems. So this patient was treated with MPT initially, bortezomib, dexamethasone, and progressed 5 months after the stop of Velcade and dexamethasone. And you can see here from the different studies with bortezomib, with carfilzomib, and ixazomib that the cardiac disease that you expect with carfilzomib goes between 6 and 7% grade 3 and 4 of heart failure, and 9% of atrial fibrillation. If you go to all grades, it goes up to 20% for atrial fibrillation and 15% for heart failure, while with ixazomib you expect only 3%, which is exactly what you see with lenalidomide and dexamethasone. And as I previously shown to you with carfilzomib, in the different groups, in the different studies, all the cardiac problems is approximately 10 to 15%. The patient received IRD in the named patient program, VGPR after 4 cycles of therapy, and 16 months without progression. So the conclusion, I think, from all these real-world data is that IRD is an all-oral combination with manageable low toxicity rate, where the real-world data are similar to what it is described in the registration clinical trial. And with that, I would like to thank you so much.
Bueno, buenas tardes a todos. Vamos a abrir una pequeña sesión de preguntas antes de ir a los casos clínicos. La idea es que las preguntas las hagan en castellano y el doctor va a tener traducción. Así que con respecto a la exposición que tuvo, si alguien tiene alguna pregunta, consulta, comentario.
Bueno, tenemos que abrir nosotros, entonces.
Bueno, Gonzalo, te cedo la palabra.
Siempre es interesante ver...
Sorry, because I try to hear the English. Now, yes.
Okay. Siempre es muy interesante ver todos los análisis de evidencia real que implican muchas veces trabajos colaborativos entre grupos, a veces de distintas nacionalidades, como hemos visto, y un poco por cómo es nuestro sistema de salud tan heterogéneo, con distintos actores privados, públicos, nos cuesta mucho lograr este tipo de registros o de evidencia. Entonces la pregunta era si hay alguna sugerencia, algún consejo importante que nos pueda dar para lograr esto.
Okay, first of all, in the Greek myeloma study group, we are a much smaller country than Argentina. We are 10 million and not so long like Argentina. But I think that with the electronic systems that we have now, it's easy to have data. I think determination is the most important factor. We need determination from many physicians because, every time that we have a new myeloma patient, this has to be registered in our system with many different data that you need. It's not only beta-2, albumin, or the sites of bone disease, also the cytogenetics, and then you have to follow the patient every cycle and put the data at the time of relapse or the time of response, and then what is the second line therapy. I mean, you need a lot of determination in order to do that. But we have now in our registry approximately 5,000 patients. But when you have something like that, I can tell you that it's easy to have, first of all, publications to be well known, I mean, to show what you are doing, because otherwise it's extremely difficult. Because if you have low number of patients and you want to publish something, it has to be very, very new. And I don't think that from a registry you can have something new. What you can have is to say that this is what we are doing, this is our results. You can see prognostic factors. You can see easily if you have 2,000 or 3,000 patients, if this, for example, the frailty score system, if it works. For example, when we've seen for the first time the IMW G-score and you have this data in your database, it's easy to have. It's only 1 week of work and we had a hematological paper. When we seen some years before about hypercalcemia, let's say we had the result, immediately we had a publication with Journal of Hematology. I mean that if you have good data in a registry, then you can easily have a confirmatory of something more important, even for the revised ISS. We had, let's say, within a month of the time of publication of ISS, and publication again in hematologica from our group. It is important to have a registry, but it needs a lot of work from the participating centers.
¿Y han hecho a raíz de este tan buen registro que pueden tener algún estudio de costo-efectividad o de farmacoeconomía en el tratamiento del mieloma?
Sorry, but
Cost effectiveness study
okay.
with all that data.
Okay, the cost effectiveness is also something important that it's difficult to be done in different systems. So, for example, if you go to Switzerland, the prices are totally different compared to Greece. So you have to remain in specific countries, or you have to compare with other drugs if you want to do comparison with other regimens, but from the same country. When you have 4 or 5 countries, in order to have a cost-effective analysis becomes a little bit difficult. Also, other countries take into consideration in the system the hours that the doctors or the nurses work. In Greece, for example, even if someone has a treatment in the day clinic or goes into in the ward in order to receive a treatment, more or less the cost for the system is the same. They don't take into consideration how many hours the patient remains in the day clinic or not, like in other countries, for example. So it is important. It has to do with the different systems. From the majority of the countries where the hours of the nurses, the hours of the doctors are important, and the hours that the patient spends to the hospital also is important, I think that an all-oral combination is always much better compared to intravenous drugs, drugs that the patient has to come a lot. For example, if you give KRD, if you give DAR-RD or IRD, with our IRD, let's say for us, during the first cycle, we say to the patient who comes after 15 days just to have a blood test, and then we follow every month.
Should be cheaper.
With KRD, for example, the patient has to come at least 6 times per month in order to have the infusions and stay in the hospital.
Thank you. ¿Más preguntas?
Bueno, yo le hago una pregunta antes de ir al caso clínico. ¿Cuál es el tratamiento inicial que le ofrecen?
Sorry, but I don't hear. I hear only Spanish. I don't hear the.
Ahora, ok. En su centro, en su lugar de trabajo, ¿cuál sería el abordaje o el tratamiento inicial a un paciente de alto riesgo citogenético? ¿Cuál sería la secuencia de acuerdo a lo que hablar?
Yeah. First of all, let's say 1 year before, we have given VTD as induction in someone who is eligible for transplant. Now we have license to give VRD. So we gave VRD 4 cycles, then autologous transplantation, and then for maintenance, again, 1 year before, we gave only Velcade. Every 15 days, 1 dose of Velcade. Now we add lenalidomide to this, so we give VR maintenance. Lenalidomide 10 milligram every day, Velcade 1 dose every 15 days. In the United States, I know that in many centers they give ixazomib plus lenalidomide maintenance for the high-risk population. But definitely, I think that lenalidomide is not enough. The meta-analysis has confirmed that for the high-risk cytogenetic does not offer any advantage. So you need either to give Velcade, if you cannot give VR, or VR. As I show you in Atlanta, this study was from Atlanta, they gave even VRD as maintenance for the high risk, and they managed to have, I think, a very good result of a median PFS of 32 months.
1 transplant?
One, for us, we are giving 2 transplants. We are giving 2 in the high risk. We give 2 transplants, yes.
Doctora Shanley.
Hay algunos pacientes que tienen un comportamiento atípico, errático, probablemente por la heterogeneidad clonal que usted mencionaba previamente. Pacientes que tienen un riesgo estándar citogenético al diagnóstico, reciben un par de ciclos de tratamiento, debutan también con enfermedad extramedular y un componente importante, infiltración masiva, y responden en unos sitios y no responden en otros. O sea, muchas veces disminuye el componente monoclonal, desinfiltran, la médula permanece, la masa extraósea. En esos pacientes que seguramente es por esa heterogeneidad clonal, ¿cómo los maneja? ¿Los considera refractarios después de un par de ciclos, a pesar de que tienen respuesta en algún sitio? ¿Considera la opción de poliquimioterapia como para hacer un tratamiento más intensivo, o cuál sería su manejo?
Yeah, the second. So when we have extramedullary disease and extramedullary disease, non-skeletal one, I mean in the liver, even in the skin that we see very often in the last few years. If you have extramedullary disease, then we try to treat these patients like plasma cell leukemia patients. If we talk about first-line therapy, we try to give VDT-PACE for 2 or 3 cycles and then to go to transplant if they are transplant eligible, because on the other hand, you have the toxicity, and if the patient is elderly one, so he cannot tolerate a lot of such VDT-PACE type regimen, even if you reduce the dose of chemotherapy. I believe for such aggressive disease like the extramedullary disease, you need chemo also. And in the relapse setting, when we see extramedullary disease, because we are doing regularly PET-CT in these patients, then we try to give like VDT-PACE or VRD-PACE, we give KRD-PACE, for example, in such patients. Everything else that we have tried has failed, even combinations like DARA-POM-DEX, K-POM-DEX. I mean, if you don't give chemotherapy in patients with multiple extramedullary disease, I don't see good results. But I don't know if you have the same experience. I don't know. You have the same, yeah.
Exactly the same.
Exactly the same. Yeah.
Micrófono, Nati.
Lo que notamos es que nosotros tenemos algunos pacientes en realidad ya recaídos refractarios a varias líneas de tratamiento, a veces de alto riesgo de inicio y a veces no de alto riesgo de inicio porque se han vuelto refractarios después de varias líneas de tratamiento y que en general responden a la poliquimioterapia. El tema es que la toxicidad de la poliquimioterapia hace que ese sea un tratamiento limitado a un número de ciclos. A veces hemos hecho... Sí, hemos hecho a veces 1 año de tratamiento, pero la verdad que la tolerancia al tratamiento, sobre todo con esquemas tipo DICEP o pase con poliquimioterapia, en un momento llega a ser una condición limitante. En esos pacientes, ¿usted consideraría alguna estrategia de mantenimiento posterior con alguna nueva droga? O sea, mejorar la enfermedad quizás con un tratamiento de quimioterapia, unos ciclos, y luego pasar a algún tratamiento, ya sea con ixazomib, con DARO, con alguna otra droga de mantenimiento menos intenso a largo tratamiento para poder mantener esa respuesta?
Yeah, we have done that when we have failure or the patients are elderly and they cannot tolerate very aggressive chemotherapy like VRD-PACE, for example. But the results are disappointing in the majority of the patients. Of course, there are patients who respond indifferent. Other patients who respond to Darapom-Dex, either KRD, even IRD. We had a patient with a liver plasmacytoma who responded to IRD, but this response lasted only for 8 months. So, I mean, and then when we gave Darapom-Dex, for example, had no response, and the patient died because of sepsis after a while. So I mean that they are, this is an unmet need. I mean extramedullary disease, plasma cell leukemia, the real high-risk cytogenetics, high LDH also patients, or patients who relapse or progress while on lenalidomide, or patients mainly who progress on lenalidomide within 12 months after transplant, on lenalidomide maintenance. I think all these categories are high-risk disease that we don't have a real good treatment. And for this, all these new techniques with BiTEs, for example, or with CAR-T cells, there's no a trial with an Amgen product, a BiTE, that tries for high-risk patients to, let's say, randomize them for 2 transplant or 1 transplant plus their CAR-T product in order to see if they can manage to have higher MRD rates compared to 2 transplants, for example. And mainly with 1 transplant plus CAR-T, you may have better probability of better response, or a BiTE, I don't know. But definitely this is an unmet need and we need other approaches.
Bueno, si les parece, vamos a los casos clínicos. Son casos reales de 2 pacientes. El primero lo va a presentar el doctor Corso del Hospital de Clínicas y después va a dar lugar a la votación, que todos tenemos el votador electrónico que nos dieron en la entrada. Ariel.
Bueno, este es un paciente que actualmente tiene 78 años, con antecedentes de diabetes, hipertensión y un bronquítico crónico, EPOC, un tratamiento con enalapril e insulina, que tiene un diagnóstico en agosto del 2014 en el contexto de una compresión del cuerpo vertebral del E4 y lesiones óseas diseminadas en el contexto también de anemia y hipercalcemia, de un mieloma múltiple de tipo IgA-kappa, un estadio ISS2, una médula ósea que tenía un 80% de infiltración clonal y un citogenético que, que se evidenciaba por FISH alto riesgo con una translocación 14-16. Un performance status de 1, ese era el laboratorio que básicamente tenía, donde tenía la anemia, el calcio elevado, un LDH para los parámetros del laboratorio del hospital normal y una beta 2 micro ligeramente elevada, no mucho. El paciente en ese momento, que estábamos en septiembre del 2014, tenía 73 años, fue tratado con 12 ciclos de BCD, obtiene una respuesta completa. En ese momento pasa luego a un mantenimiento con bortezomib de forma quincenal, que lo tiene que suspender un año después por presencia de neuropatía. Y por las lesiones óseas completó 2 años de ácido zoledrónico con aporte de vitamina D y calcio. En junio del 2018, luego de 4 años de estar en remisión completa, reaparece nuevamente su componente monoclonal IgA-kappa, presentando, bueno, ahí no, el corrector tenía nuevamente anemia asintomática y nuevas lesiones óseas. La lesión y la médula ósea tenía 50% de infiltración y se evidenció nuevamente la 414, pero con la adición de la amplificación del 1Q. Se había adquirido una nueva alteración citogenética de alto riesgo. Entonces nosotros en ese momento uno se plantea estas preguntas de acuerdo al riesgo citogenético elevado que tenía un paciente. Recordemos que tenía a esa altura ya 74 años, con esas comorbilidades, ¿cuál sería para ustedes, de acuerdo a lo que se evidenció, la mejor estrategia o la mejor combinación? La idea es que puedan votar.
Así que voten.
No pretendo hacer la musiquita, así que...
Tararear bien. A los segundos ahí.
Bueno, aprovecho para decirles que tienen para descargar el score de fragilidad, lo cual me ayudó mucho a mí para decidir en ese momento la decisión. Ahora, por suerte, ya lo tenemos en el celular, que es mucho más práctico. Bueno, la mayoría votó Rixarenadexa. Bueno, este paciente, al hacerle el score de fragilidad, era intermedio, de un medio, con un score de 3. Decidimos en conjunto en el servicio hacerle un protocolo con IRD. Luego de 10 ciclos de tratamiento, el paciente adquiere una respuesta completa y actualmente va completando el ciclo 12 con muy buena tolerancia y sin grandes complicaciones. La verdad que la idea era comentar a este paciente, ya que fue tratado con un protocolo de IRD con buena tolerancia, sin grandes complicaciones, actualmente con 12 ciclos. Con respecto a sus efectos adversos, tuvo una toxicidad de una plaquetopenia leve, que no tuvo que suspender ni el ixazomib ni la lenalidomida, así que la verdad que la tolerancia fue buena. Y la idea era también comentarlo porque era un paciente que ya había sido previamente expuesto a un inhibidor de proteasoma, pero no era refractario, sino que se había tenido que suspender por toxicidad, por el tema de la neurotoxicidad. La plaquetopenia fue más o menos la esperable, que se había evidenciado también con el bortezomib, y también que obtuvo nuevamente respuesta al ser de alto riesgo citogenético con estas dos alteraciones, y también un poco consensuado con el paciente, que ya quería, la verdad que el paciente vivía en el interior y venía una vez al mes, entonces se consensuó con un tratamiento oral y fue básicamente la decisión, y que hoy retrospectivamente ambos estamos conformes con la decisión que tomamos. Más allá de eso, y aprovechando el expertise del doctor en la enfermedad ósea, mi pregunta, más allá del comentario, si puede hacer, si en estos pacientes que recaen y que nuevamente tienen afectación ósea extensa, y es uno de los CRAB más importantes que llega a tener, ¿cuál sería la mejor estrategia en este contexto? ¿Reexponerlo nuevamente al mismo bifosfonato, cambiarlo, otra molécula?
Okay, first of all, for the bone disease, regarding the initial case about treatment, I agree that a patient who is frail with comorbidities, I think, and high-risk cytogenetics, IRD, is offering probably very, very good results. But okay, I can agree also with the people who voted about DARA-RD that the results are similar. So if you could have subcutaneous DARA, because otherwise the 6 hours to be in the clinic and also some allergic reactions that the intravenous drug has, daratumab, they may be difficult for an elderly patient. If I had the subcutaneous that we use now in clinical trials, then I would say that this also could be an option. And then you take other things into consideration, like the cost or other things. But I believe that this is an ideal patient for IRD with very good results, as you've shown. Regarding bone disease, the guidelines suggest that you can use, of course, zoledronic acid again at the time of relapse. the decision to change to denosumab, I don't know if it is available in Argentina, denosumab, I don't know, is this? Okay, so denosumab has some important advantages. The first is that it's not clear through the kidney, so if you have a kidney failure, for example, it's much better. The second is that at least for the newly diagnosed patients, because we don't have any data for relapsed refractory, the newly diagnosed has a PFS advantage. And this advantage is mainly in patients who received a transplant. So we don't know why, we haven't seen all the data yet because we need to take care of some of the data. But in these patients, we have approximately 11 months of median PFS advantage. And I think that this is something that you have to take into consideration when you talk about first-line therapy. But we don't have any data about the relapse. So the only, for me, reason to change from zoledronic acid to denosumab in the relapsed or refractory setting is the creatinine clearance of the patient. If the creatinine clearance is, let's say, below 50, then the drug is more safe, denosumab I mean, then I would change for that. If the creatinine clearance is normal, then you could give Zometa as before.
Okay. Gracias. Gonzalo, seguís con tu... una pregunta, sí.
Micrófono.
No,
Schutz,
un
micrófono.
comentario.
¿Qué?
Comment.
Me gustaría, dado que el doctor tiene muchísima experiencia con denosumab y por el mecanismo de acción es una droga muy atractiva para mieloma, más en pacientes con insuficiencia renal, si pudiera comentar un poco respecto al riesgo de fracturas rebote vertebrales luego de la suspensión y el manejo en esos casos. Si uno debería hacer algún bridging con pamidronato o qué tener en cuenta en esos pacientes si uno lo va a suspender.
You are from Italiano Hospital, is it correct? I'm going to discuss it tomorrow. Okay, but this is a very interesting. Yeah, but I have some slides if you want to share with all of you about the. Can I put some slides? Is it possible? Okay, because it's nice.
Mira lo que haces.
I mean that's to show you why we talk about fractures after the stop of the drug. Can we put it somewhere? I don't have any. Okay. We don't have data in multiple myeloma, but the question had to do because of data in osteoporosis. And in osteoporosis, we had a rebound effect, suggesting that after stopping denosumab, some of the women had fractures, and these women were those who have not received the bisphosphonate before. Of course, I have not explained, like I'm going to do tomorrow, about pathophysiology in the two drugs, but the European Calcified Tissue Society formed a group of most important osteoporosis people in order to see what happened in this phenomenon. And you can see here, this is the CTX, which is the bone resorption marker. In this study, the patients received either placebo, like here, or denosumab for 24 months, and then denosumab was stopped. So when denosumab was given, you can see that the bone resorption marker went down by 90%. So bone resorption was stopped. And this continued for 24 months. When you stopped here denosumab, you can see that the bone resorption went up by 60%. Why? Because, and more importantly, in the next slide, I'm going to show you that the bone mineral density in the lumbar spine, the total hip, and the radius was dramatically increased with denosumab for the 24 months. You can see here who have 7-fold higher bone mineral density compared to placebo or even more. But when you stop denosumab in month 24, you can see that even after 12 months, you lose everything that you gained. You see that the bone mineral density went down. So you lost all the effect. Why is it so? Is it because zoledronic acid and the other bisphosphonates kill the osteoclast? It means that the bisphosphonate goes into the hydroxyapatite and kills the osteoclast. I'm going to show that. Okay, it's not a problem. So this is why, here it is. So this is with the green color is the zoledronic acid. So zoledronic acid goes to the hydroxyapatite. You see here the osteoclast. And as the osteoclast resorbs the bone, it takes into the body of the cell the fragments of the hydroxyapatite, which is the salt of the bone, with the zometa, with zoledronic acid, or any bisphosphonate, and the bisphosphonate kill the osteoclast. On the other hand, the monoclonal antibody against rank ligand make the osteoclast to be inactivated. So the denosumab does not kill the osteoclast. So the osteoclast remain there. So when you put out denosumab from treatment, then the osteoclasts that are there and alive, they have not been died because you have never given a bisphosphonate, then they start working immediately and you may have not only a rapid bone loss but also a fracture in these areas. So, is this the same in myeloma? First of all, we don't know, but and I will tell you why I say that. So, in osteoporosis, the guideline is that for patients who have a decision to discontinue denosumab, that in this case is after 5 years, a bisphosphonate therapy should be considered to reduce or prevent the rebound increase in bone turnover. Why? Because when you give one dose of a bisphosphonate, then when you remove the inhibition of the osteoclast from denosumab, then the osteoclasts start working, but then they are going to be killed because of this bisphosphonate. So when denosumab should be stopped, then you have to do it considering alternative treatment in order to prevent rapid bone mineral density. And the suggestion is to give one dose of zometa, for example, after 6 to 9 months. So, is it the same in myeloma? I'm not sure. Why? I'm not sure. Because in myeloma, you give anti-myeloma therapy, including, for example, dexamethasone, including lenalidomide, and bortezomib, that all of these drugs, mainly bortezomib and lenalidomide, are toxic for the osteoclast. So probably at the time of treatment, you have killed these osteoclasts, so they are not alive when you remove denosumab. Of course, this has to be proven. We are going to have this proof because in the denosumab versus zoledronic acid study, after 2 years of denosumab, the patient could say that I want to stop. And approximately 20% of the whole population have chosen to stop denosumab. So these patients continue without anything. So of course, this has to be proven. We are going to have this proof because in the denosumab versus zoledronic acid study, after 2 years of denosumab, the patient could say that I want to stop. And approximately 20% of the whole population have chosen to stop denosumab. So these patients continue without anything. So we are going to see if these patients are going to have fractures or not. Sorry for this interruption, but I wanted to show more
Bueno, por una cuestión de tiempo, el próximo caso era disparador de la discusión de qué hacer con pacientes refractarios de alto riesgo, y se trataba de un paciente joven. Entonces, lo que voy a tratar es de, respecto del paciente que íbamos a presentar, y en aras del tiempo, que ya estamos en hora para finalizar, la pregunta era sobre un paciente joven que fue de alto riesgo citogenético, concretamente una de lesión 17P, que fue sometido a trasplante autólogo en su primera línea y que recae habiendo interrumpido el mantenimiento con lenalidomida. ¿Sí? ¿Cuál sería hoy su elección como rescate, como segunda línea, KRD, IRD o alguna otra sugerencia?
Okay, so we talk about a patient who received therapy, autologous transplant, plus lenalidomide maintenance, and progressed while on lenalidomide.
No, he stopped.
He stopped lenalidomide.
Yeah.
For how long?
More than 6 months.
More than 6 months. And start to have biochemical relapse or aggressive relapse?
Clinical relapse.
Clinical relapse. So, yeah, for this patient with high-risk cytogenetics, you have all the options available of the high risk. I mean, you can give KRD, IRD, or DAR-RD. You have to discuss with the patient. This is what we are doing in a young patient. If the patient was elderly, no doubt I would go for IRD. Then we discuss what are the data that we have. For deletion 17p, all three combinations are good. So we discuss the data, and I can tell you that the majority of the patients want to have an IRD regimen.
Una última. El doctor Corso no quiere. No hay lugar. Así que bueno, una más, Ariel. Déjalo, que viene de Necochea.
Que viene del sur.
¿Qué tal? No, le quería preguntar si en su país tienen la posibilidad de hacer sorting a todos los pacientes para el estudio de mieloma. Y la segunda pregunta es si con respecto al mieloma y la translocación 11-14, si con estos estudios, bueno, que se ha suspendido temporariamente el venetoclax, si cree que quizá puede llegar a tener algún futuro o es un tema ya cerrado.
Okay, regarding the first question, if we are putting all our patients in clinical trials, the answer? Sorry, the question is if we put all the patients in clinical trials, or how many of the patients. If this is the question, it depends on the center. Let's say in our center we put approximately 70% of the patients in clinical trials. That's why our boss is first author in almost all important publication. This is why we have created a very good clinical trial center with approximately 52 people who work on that. And we have now more than 500 patients on clinical trials. Now that we talk, I think it's 580 patients on clinical trials. But this means that even these 52 people are not enough. There are, of course, study nurses, doctors, and study coordinators to put the data into the systems and everything. But we have a lot of patients, or even these 52 people are not enough for this very high burden of patients. You need to have very good infrastructure to participate in clinical trials, because the clinical trials are becoming more and more demanding during the last years. Let's say when I had started in 2007, and now there's nothing to do, let's say, and the inspections that we have, because we had 3 inspections by FDA and 1 by EMEA, the European Medicinal Agency, becomes more and more strict. When they come, every time it is stricter than the previous one. So you need to have a very, very good infrastructure, and to be very careful what you put there. The people have to be trained in clinical trials. I don't think that everybody can do it, because this was my initial mistake. I thought that if you have even a nurse that is not experienced, it is easy for her to put the data into the computer. No. This is not like that. The discrepancies are extremely high. So, and this was our main problem initially. So in order to reduce that, you need to have experienced nurses and also to have an internal quality control. You have to have someone to check what the nurses are doing. This is, I think, our success, that we have done so good job in that thing. So regarding the second question about venetoclax, to be honest, we participated in one study, but we had put only 5 patients on that. We haven't seen any safety signal, but probably it was in a bigger number of patients, they've seen that. So I don't know if it's going to restart, but in these 5 patients who had 11, 14, we gave it with Velcade. All of the patients responded. We have not had any problem, but as I mentioned, probably in the whole population, they've seen some safety issues that made them stop the trials.
And do you do sorting in all of your
Yes,
tests?
yes.
No. No, breve, no, shoots.
Yo voy a comentar un poco en base a la pregunta a la pregunta del doctor, es que desde hace un año existe en la Sociedad Argentina de Hematología una subcomisión de investigación clínica. Argentina tiene algunos estudios, pocos, la verdad que la porcentaje de población que debemos tener en estudio debe ser 1%, pero tenemos algunos centros y participamos de algunos estudios clínicos. Una de las dificultades que tiene el país es el enrolamiento, esa es la mayor desventaja. Tenemos muy buena calidad de datos en los centros que hacen investigación, que son pocos, pero tenemos que trabajar en el enrolamiento. Y una de las principales cosas para trabajar en el enrolamiento es que nosotros como médicos creamos en las ventajas de la investigación clínica y que empecemos a trabajar con las sociedades de pacientes para concientizar a los pacientes que esto también es una opción más. Como tenés el tratamiento A, tratamiento B, tenés la opción de participar en un ensayo y en eso estamos trabajando. El primer paso de la subcomisión de investigación clínica es quizás fortalecer los centros que ya están haciendo investigación, trabajando en la problemática común que todos tenemos. Pero el segundo paso, que es más ambicioso, es darle soporte a otros centros que quieran empezar a hacer investigación, en transmitirle este know-how que a veces es difícil de adquirir, porque tiene toda su propia metodología, su propia forma de trabajo y algunas cuestiones que se necesitan. Por ejemplo, el study coordinator, dice más, sin un study coordinator no podés sobrevivir en un estudio clínico. O sea, hay algunas cosas y esa transferencia de conocimiento es lo que pretendemos dar desde la Sociedad Argentina de Hematología y la subcomisión, en la medida que, digamos, el primer paso va a ser fortalecernos nosotros y el segundo paso va a ser ayudar al que quiera hacer investigación clínica, poder desarrollarlo localmente siempre y cuando tenga las condiciones mínimas para hacerlo, que nosotros también le vamos a tratar de transferir ese conocimiento de qué se necesita para el que esté interesado. Así que bueno, en eso estamos, por eso iba el comentario, porque iba muy apropiado de la parte de su pregunta.
I think that the most important thing is to have good clinical trials. I think that what you described is good, but it's mainly for North European countries, what you said. I think you are an emotional nation like us, so if you say to your patient that I believe that this is the best for you, you are not going to have any problem on that. So if you have good clinical trials that you believe that it is good for your patient, I don't think that in Argentina, from what I have seen, the patient can say no. All the others about patients, groups and everything is only for the more cold people of the north. So I mean that they are, okay. They take into consideration other things, not what the doctors believe. What is my status? What is my work? I want to go to the work. You know, they take other things into consideration. So from us, let's say I have a study with DARA VRD versus VRD, the Perseus study, for example, first line for the eligible patient. If I say to my patient, okay, VRD, you can have it in Greece, but you have 50% probability of having something that gives 70% of MRD negativity. And I would be happy if you were in this 50%. Everybody agrees to be in the study. Or then at the maintenance, you may receive also daratumab with lenalidomide, which is even better. I mean, if you have something like that, nobody's going to say no. Of course, if you have a study that, let's say, is not so good, but it is even, or you don't believe that the data are very good, to say to your patient, then if it is the last chance that the patient has, also he may participate.
Una de las dificultades, bueno, creo que una de las cosas que yo siempre soy así, y hoy estoy con una dosis de dexametasona, me pone peor. Sí, breve. No, le voy a hacer solo una pregunta, porque esto nos pasa, digamos, los primeros que tenemos que estar convencidos es que hacer investigación clínica y ofrecerle un ensayo clínico es una buena opción para el paciente. Nosotros, Argentina participó del estudio Alcione, participamos del estudio Condara en mantenimiento, de la Aquila, o sea, tenemos estudios, no todos, tenemos pocos, pero tenemos estudios Tourmaline, también lo tuvimos, que son atractivos por lo menos desde el punto de vista de la comunidad de mieloma. Entonces mi pregunta es, ¿usted cree que la investigación clínica beneficia al paciente?
Definitely for many patients, because I haven't seen a real, let's say, negative study for many years. I mean, the phase 3 studies, also, from the company point of view, let's see the company. Do you believe that the company wants to spend, let's say, 1 billion, for example, in order to have a negative study? No. I mean that, so that's why we have very few negative studies. But, okay, to be honest, the only study that I was disappointed by the result was the panobinostat studies, that I had put patients there and they had side effects with gastrointestinal toxicity that we didn't know from the phase 2 studies. So this was the only type of studies that I said, no, it was not a good idea to set it. But all the other studies, they were for patient benefit, because those who were, let's say, randomized in the good arm, let's say, that they had even DARA or another drug, they had a better PFS, better overall survival. And the others didn't miss anything because they took the standard. And also it's good for the hospital, suggesting that we don't spend, because in Greece, let's say, there is a budget for every hospital, so there is. So with the money that we managed to have from the clinical trials, or the reductions from because of the free drugs, we managed to give in other diseases that we are not so much specialized. Let's say we can give ibrutinib to our CLL patients or to Waldenstrom patients, that's very expensive. And if we had to give both daratumumab, ibrutinib, and everything, then the budget would not be enough. So I think that there is a benefit for everything. Yeah.
Bueno, muchas gracias a todos por venir. Mañana hay un workshop en el Hospital Italiano con el doctor Terpos, no sé si hay lugar para que alguien pueda asistir, y pasado mañana en el Hospital Alemán, viernes por la mañana, el que quiera venir me avisa y será bienvenido. Gracias.